we're not making the progress against hypertension that we need to. And many people are out there with very high levels of blood pressure that are not getting attention. And this has to change. I want to talk about a paper we've just done, but let me lay some background. We're losing ground on blood pressure. Almost every population-based study is showing that, in fact, blood pressure levels are getting worse around the nation, not better. Moreover, it seems if you look within the electronic health records of most major institutions, there are lots of people who've had repetitive elevated blood pressure levels and are not getting the care that they need. Our group has been focusing on ways in which we can do digital population health surveillance using the electronic health record to identify these individuals and to link them with the kind of follow-up and care that they need. The key will be to be able to identify, classify, and then triage appropriately these individuals. In the course of this, we've developed a concept of persistent hypertension. Most people know about resistant hypertension. That's an elevated blood pressure despite the concurrent use of 3 or more antihypertensive medications. But we introduced a construct, a framework called persistent hypertension, a broader construct for the larger number of people whose blood pressure repetitively remains high despite our interventions. And the resistant hypertension is just one of the causes that leads people to be in that position. People can have high blood pressure but lack insurance and medication affordability. They can have a hypertension diagnosis, but people can fail to really recognize and move in and make changes. There can be issues around treatment plans or adherence, consistent follow-up. So there's all sorts of things that can conspire against people being able to achieve blood pressure control that go beyond the fact that their body just doesn't react in the way we would expect to antihypertensive medications. So we tried to identify a group of people within the Yale New Haven health system who had a blood pressure of 160 or systolic or 100 diastolic elevated for 5 consecutive visits, and without being able to be under control, getting it below those very elevated levels, and tried to understand what the heck was going on. What was it that was underlying this? And could we group people by the sort of underlying cause? Now, most doctors who are caring for these patients know that there are multiple reasons why people are unable to achieve their goals, but we're trying to standardize this in ways that could help us to properly triage people to places where it might be able to help them. So, for example, some people might need a health educator, some people might need a social worker, some people might need a pharmacist, some people might need a primary care physician, some people might need a specialist. So could we expedite this and facilitate the connections with people to overcome the main barrier to their ability to get their blood pressure under control? Now, when we went through this in very systematic ways using qualitative research methods, we were able to identify 3 content domains, general domains, that were related to this persistent hypertension. One was a non-intensification of pharmacologic treatment. So as this is the absence of antihypertensive treatment intensification in response to this persistently elevated blood pressure, the healthcare system, we healthcare professionals don't seem to be reacting to the fact that this person's got very elevated blood pressure levels, and it's repetitively so. Another was non-implementation of prescribed treatment. So the healthcare professional actually made the prescription. There's documentation in the chart, but there are barriers, reasons why people didn't follow up and weren't able to complete that task, that prescription. And then, of course, there is the third cause, which is non-response to prescribed treatment. So clinician acknowledged persistent hypertension, and then the prescription of appropriate pharmacologic agents, the feeling, the evidence, the report that people are actually taking these medications, and yet the inability to get people under control. So within each of these, there were subcategories and reasons that underlied them that could then further refine what we might do about it. In each of these situations, we believe that based on the medical record evidence, we can begin to determine what might be the proper match for what each person needs to be able to make progress. And this isn't just a matter of what's on the doctor to do. Again, this non-intensification in a situation where there's an indication was only one of the many reasons why we really weren't making progress. And I think the clinicians, we need help, because oftentimes the barrier there is not actually something we can directly control. We need the experts of other people, other teammates who can help us make progress. And the thought is that this can help us. So this study presented a novel pragmatic taxonomy for classifying patients with persistent hypertension by their contributing causes. And it was, importantly, this taxonomy derived directly from real-world data that exists within the EHR. And so that these could really be ultimately automated and put into tools that can help us be able to make these proper connections. Look, if we're going to make progress against hypertension, we need some new ideas, some new approaches. And it can't be just about what happens between the doctor and the patient. It's about bringing a team to bear, recognizing that there are lots of other causes, and we need to work together across expertise in partnership with the patients if we're to make the progress that we need. Otherwise, we will continue to have people walking around with these markedly elevated levels of blood pressure at extreme risk and inevitably getting into trouble as a result. And really, we can preempt, prevent, we can help these people live healthier lives if we can all work together and make this go.